Tonight, while you sleep, your liver is going to betray you. Between 3 and 8 in the morning, before you've eaten a single thing, before you've had any coffee or any food at all, your liver is going to flood your bloodstream with glucose. It happens every night. It has a name, the dawn phenomenon, and over half of all people with type 2 diabetes experience it. You wake up, you check your number, and it's already high, not from what you ate, not from anything you did wrong. Your liver did it while you were sleeping, and here is the question your doctor probably never answered. If that's happening every single morning, why is the first drink you reach for doing nothing about it? I'm Dr. Michael Reed. What I want to show you today is the research, peer-reviewed, published, measured in real patients, behind 3 specific morning drinks that work directly on the metabolic mechanisms that make your blood sugar hard to control. Not folklore, not marketing. The actual biology, and why it matters specifically to someone your age. By the time this video is over, you're going to understand why your fasting glucose is high even on medication, why belly fat makes the problem worse by the year, and exactly what to drink in the morning and why it works at the cellular level. That understanding is the difference between guessing and knowing is how you start moving numbers. If that kind of content is useful to you, no fluff, no promises, just the science translated into something you can actually use, subscribe. That's what this channel exists for. Let me start with something that took me years to say plainly to my patients. Your doctor is not wrong, but the guidelines they follow are written years behind the research. The current standard of care for type 2 diabetes was largely shaped by studies conducted in the 1990s and early 2000s. The last decade has produced a completely different understanding of what insulin resistance actually is at the molecular level, and most of that knowledge has not made it into the average 15-minute appointment. That's not an accusation. That's a structural problem. There are over 10,000 peer-reviewed papers published every year on metabolic disease. No physician can read all of them. What I do on this channel is spend the time that most doctors don't have. Read the current research and translate it into something clinically useful for people who are living with this condition every day. I want to tell you something that I've never seen printed on a patient discharge summary, even though the evidence for it is overwhelming. The reason blood sugar is so much harder to control after the age of 55 than it was at 40 is not just that the disease has progressed. It's that the architecture of your metabolism has changed in at least 4 distinct ways. And almost none of the standard treatment protocols are designed with those 4 changes in mind. Your medication targets 1 or 2 of them. The rest continue unchecked. And the morning choices you make, including what you drink in the first 60 minutes after waking, can either feed those unchecked mechanisms or begin to slow them down. That is not a statement I make to alarm you. I make it because understanding the mechanism is how you stop being passive about this condition and start being strategic. The patients I have watched make the most meaningful improvements in their metabolic numbers over the course of a decade are not the ones who simply took whatever pill they were prescribed and waited. They are the ones who understood what was happening inside their bodies, made targeted decisions accordingly, and tracked their data. That combination, understanding, targeted action, and data, is what this video is about. So let's talk about what is actually happening inside your body, and why it gets worse, not better, as you get older. Here is the first thing you need to understand. Your muscle is a glucose disposal machine, not a small one, a massive one. At rest, and especially after eating, your skeletal muscle is responsible for absorbing somewhere between 80 and 90% of the glucose that enters your bloodstream from food. 80 to 90%. Your muscle is not just there to move you. It is the primary metabolic organ that keeps your blood sugar in a healthy range. When patients come into my clinic frustrated because their A1C keeps climbing even though they're eating less than they used to, this is usually the first piece of biology I explain to them. Because what they are experiencing is not a failure of willpower. It is a failure of a system that has been quietly degrading for 15 years without anyone explaining the mechanism to them. Now here's what happens after 50. You start losing muscle. The medical term is sarcopenia, and it begins earlier than most people realize, around age 30. But it accelerates significantly in the decade between 50 and 60 and again after 65. Adults who are not specifically working to preserve muscle can lose 3 to 8% of their total muscle mass per decade. By the time someone reaches their mid-60s with type 2 diabetes, they may have lost 30 to 40% of the functional muscle they had at 40. Think about what that means for blood sugar. If your muscle is doing 85% of the job of clearing glucose from your blood and you've lost a third of that muscle, the math is simple and brutal. The same amount of food creates a significantly larger blood sugar response than it did 20 years ago. The sink is smaller. The water backs up. Here's the part that doesn't get discussed at annual diabetes checkups. Insulin resistance doesn't just cause blood sugar problems, it also directly inhibits the synthesis of new muscle protein. This creates a feedback loop that accelerates the problem over time. High insulin resistance leads to less efficient glucose uptake by muscle. Less efficient glucose uptake means cells have less fuel for protein synthesis. Less protein synthesis means muscle mass continues to decline. Declining muscle mass means even less capacity to absorb glucose. The cycle feeds itself, and conventional treatment that focuses only on the glucose number without addressing the underlying insulin resistance does almost nothing to interrupt it. A review published in Medicina in October 2024 analyzed data from the Framingham cohort and the N. Haynes III study. Researchers found that adults between 65 and 80 with what they called sarcopenic obesity, that combination of lost muscle and gained fat that is extraordinarily common in people with long-standing type 2 diabetes, had significantly higher rates of metabolic dysfunction, and their HOMA-IR scores, which is the measure of insulin resistance calculated from your fasting glucose and fasting insulin, averaged 1.73. For context, a HOMA-IR above 2.5 is generally considered insulin resistant. Many of the patients in that cohort were well above that threshold, and the combination of lost muscle with gained visceral fat created what the authors called a double metabolic hit, two problems compounding each other simultaneously. That double hit is why so many people over 60 with type 2 diabetes find that the same medication dose that was working 2 years ago is suddenly not enough. It's not that the drug stopped working, it's that your body's underlying metabolic capacity has shifted. Now here's where the morning drink conversation gets clinically interesting. When your muscle is less able to absorb glucose, your liver compensates, but it compensates in the wrong direction. Instead of releasing less glucose into the bloodstream, a diabetic liver tends to release more. The enzyme systems that control hepatic glucose production, gluconeogenesis, which is making new glucose from non-glucose sources, and glycogenolysis, which is releasing stored glucose, are supposed to be suppressed by insulin. In a healthy person, when blood sugar rises after a meal, insulin goes up, and the liver gets the signal to stop adding more glucose to the bloodstream. In type 2 diabetes, that suppression signal is broken. The liver has become insulin resistant, the same way your muscle has. So even when blood insulin levels are elevated, the liver keeps producing glucose. This is particularly severe in the overnight hours, which brings us back to where we started, the dawn phenomenon. During the early morning hours, a cascade of counter-regulatory hormones is released: cortisol, growth hormone, glucagon. This is a normal biological process designed to prepare your body to wake up. These hormones signal the liver to release glucose so your brain has fuel when you open your eyes. In someone without diabetes, the pancreas responds with a precise pulse of insulin that keeps the whole process in balance. In someone with type 2 diabetes, especially someone over 55 whose pancreatic beta cell function has declined, that balancing pulse doesn't happen adequately. The liver releases glucose. The glucose hits the bloodstream. Nothing fully stops it, and you wake up to a fasting number that has nothing to do with last night's dinner. I've had patients come to me convinced they were doing something wrong at night: eating too late, having a glass of wine, not drinking enough water, because they couldn't explain why their morning number was always elevated despite perfect dinner behavior. Some of them had been blaming themselves for years. When I explain the dawn phenomenon to them, when I show them that this is a physiological process driven by hormones, not by anything they ate or didn't eat, the relief is visible. And then the second reaction is almost always the same: why didn't anyone explain this to me before? The answer is time. It takes 6 or 7 minutes to properly explain the dawn phenomenon in clinical terms. Most appointments don't have 6 or 7 minutes to spare for mechanisms. But mechanisms are exactly what you need, because without understanding the mechanism, you can't make targeted decisions about how to address it. I want to stay with this for a moment because it's the reason the first drink of the morning matters more than most people realize. If your liver is in a state of uninhibited glucose production overnight, what you give your body first thing in the morning is not irrelevant. The compounds in certain beverages can directly influence hepatic glucose production within 30 to 60 minutes of consumption. Some of them inhibit the enzymes involved in gluconeogenesis. Some of them improve hepatic insulin sensitivity, and at least one, which I'll get to shortly, does both simultaneously, with a published effect size that honestly surprised me when I first read the data. But before we get to the solutions, there's a third mechanism you need to understand because it connects everything else together. Your fat cells are not passive storage depots. They are endocrine organs. When you accumulate fat, particularly visceral fat, the fat stored around your internal organs rather than under the skin, those fat cells begin secreting inflammatory molecules. Interleukin-6, TNF-alpha. These are cytokines, chemical messengers, and their job in the context of acute infection is to mount an immune response. But when they are chronically elevated at low levels, which is what happens with persistent visceral fat accumulation, they interfere directly with insulin signaling. Here is the specific mechanism. The insulin receptor on the surface of a muscle cell receives insulin, binds to it, and initiates a cascade of molecular signals inside the cell that ultimately causes GLUT4 transporters, glucose transporters, to move to the cell surface and pull glucose in from the bloodstream. TNF-alpha disrupts that cascade at the point of a protein called IRS1. When IRS1 is blocked, the signal never completes. Insulin docks with the receptor. The receptor fires. But the message doesn't reach the GLUT4 transporters. The cell doesn't respond. The glucose stays in the bloodstream. Think of it this way. Insulin is sending a text message to your muscle cells. Open the door and take the glucose. Chronic inflammation from visceral fat is like a spam filter that intercepts the message before it arrives. The message is sent. The recipient never gets it. The door stays closed. Here is something that took me a long time to find in the literature, but once I saw it, I couldn't unsee it. This inflammatory pathway gets worse with age, not just because of fat accumulation, but because of a phenomenon researchers now call inflammaging. The systematic, age-related elevation of low-grade chronic inflammation, even in the absence of obvious disease. As immune cells age, they become less precise and more chronically activated. In a person over 65 with type 2 diabetes, you often have the combination of visceral fat-driven inflammation and inflammaging running simultaneously. The two amplify each other. What this means clinically is that two people with identical A1C values and identical body weights can have dramatically different insulin sensitivity depending on their inflammatory burden. The person with lower chronic inflammation responds far better to the same dose of medication. They respond better to dietary changes. They respond better to exercise. Reducing inflammation is not a side benefit of metabolic treatment. It is a core mechanism. And the reason this is so important in the context of what we're discussing today is that EGCG, the primary active compound in green tea, is one of the most studied natural inhibitors of NF-κB that exists. NF-κB is the molecular switch that turns on the production of inflammatory cytokines. It is the master regulator of the inflammatory response. Pharmaceutical companies have spent hundreds of millions of dollars trying to develop safe NF-κB inhibitors for metabolic disease. EGCG inhibits it through a different structural pathway, with a safety record going back thousands of years of human consumption. This is also why I think about the morning as a metabolic window. The choice is made in the first hour of the day. What you drink, whether you move, whether you see daylight, have a disproportionate effect on the regulatory systems that determine how the rest of your day unfolds metabolically. This isn't philosophy, it's chronobiology. Cortisol peaks in the morning. The inflammatory cascade has a circadian rhythm. The first inputs your body receives after sleep set the metabolic tone for the hours that follow. Now let me tell you about the research, because this is where I want you to pay close attention. In 2024, a research team published a meta-analysis in the journal Medicine, compiling the results of 15 randomized controlled trials examining the effect of green tea on patients with type 2 diabetes. This wasn't a small study. This was a synthesis of 722 patients across multiple countries and clinical settings. The researchers measured 3 specific outcomes: fasting blood glucose, A1C, and HOMA-IR, that insulin resistance marker. The results were statistically significant across all three. Fasting glucose declined, A1C declined, and HOMA-IR, the direct measure of insulin resistance, showed a standardized mean difference of negative 0.70. In clinical terms, that is a meaningful reduction in insulin resistance. Not marginal. Meaningful. The mechanism behind that finding is a compound called EGCG, epigallocatechin gelate, which is the primary bioactive catechin in green tea. EGCG activates an enzyme called AMPK, adenosine monophosphate activated protein kinase, which functions as what researchers sometimes call the master metabolic switch of the cell. When AMPK is activated, cells increase their glucose uptake, improve their mitochondrial function, and reduce inflammatory signaling. EGCG also directly inhibits NF-κB, which is the master transcription factor responsible for producing those inflammatory cytokines, the IL-6 and TNF-alpha we discussed. Green tea doesn't just help with one part of the problem. It addresses the insulin receptor, the inflammatory pathway, and the hepatic glucose production simultaneously. An earlier meta-analysis from 2020 in Nutrition and Metabolism consolidated 27 randomized controlled trials across 2,194 subjects. That analysis found a statistically significant reduction in fasting blood glucose with consistent green tea consumption. The effect was modest in any single study, but the consistency across 27 independent trials is what matters. When you see the same direction of effect in 27 different research teams in different countries using different patient populations, you are looking at a real biological signal, not statistical noise. Here is the one thing I want to be honest with you about regarding green tea. There is debate in the literature. Not every meta-analysis has reached the same conclusions. An older analysis from 2017 found non-significant results for A1C. The 2024 analysis found the opposite. The difference largely comes down to dose and duration. The studies showing the strongest effects used catechin concentrations equivalent to roughly 2 to 3 cups of high-quality green tea daily, consumed consistently for at least 8 to 12 weeks. A single cup of low-grade tea bag green tea once a week is not the same thing. Dose matters. Consistency matters. I'll tell you exactly how to make this work in practice in a few minutes. Now let's talk about the second drink. And this one has the most striking numbers of anything I've reviewed for this video. In January 2025, a research team published a grade-assessed systematic review and dose-response meta-analysis in Frontiers in Nutrition, specifically examining the effect of apple cider vinegar on glycemic control and insulin sensitivity in type 2 diabetes. Grade methodology is considered the gold standard for evaluating the quality of evidence in clinical nutrition research. This was not a soft analysis. The findings. Apple cider vinegar was associated with a reduction in fasting blood sugar of 21.9 milligrams per deciliter. That is a 21-point drop in fasting glucose, and a reduction in A1C of 1.53 percentage points. When I present those numbers to physicians who haven't looked at this literature, the reaction is usually skepticism, because 1.53% is the kind of A1C reduction you'd expect from a pharmaceutical intervention, from a well-studied medication, not from a tablespoon of vinegar in a glass of water. But the mechanism is not mysterious once you understand it. Acetic acid, the active compound in all vinegars and present in highest concentrations in apple cider vinegar, inhibits intestinal alpha-glucosidase. Alpha-glucosidase is an enzyme in your small intestine that breaks down complex carbohydrates into simple sugars for absorption. When you inhibit it, you slow the rate at which glucose enters your bloodstream after a meal. This is, incidentally, exactly the same mechanism of action as acarbose, a pharmaceutical medication that has been prescribed for type 2 diabetes for decades. The difference is that acarbose was patented and sold. Acetic acid is in vinegar. Beyond the intestinal effect, acetic acid also inhibits hepatic glucose production. It reaches the liver through the portal circulation after absorption, and it directly suppresses the enzyme systems involved in gluconeogenesis. Remember our night shift employee, the liver producing glucose at 3 a.m.? Acetic acid can slow that employee down, and it does so most effectively when consumed either before a meal or before bed. A 2023 randomized controlled trial published in Frontiers in Clinical Diabetes and Healthcare followed 80 patients with type 2 diabetes over 8 weeks. One group received 30 milliliters of apple cider vinegar daily, mixed in water. The control group followed the same dietary recommendations without vinegar. Fasting blood glucose in the vinegar group dropped significantly, with a p-value of 0.01. A1C showed a significant between-group difference. LDL cholesterol also decreased. These were patients already on oral diabetic medications. The effect of the vinegar was additive, not instead of their existing treatment. This matters because some people wonder whether adding these drinks makes sense if you're already on metformin. For most patients on metformin alone, the answer is yes, and here is why. Metformin works primarily by reducing hepatic glucose production. It targets the liver's overactive overnight glucose release. Apple cider vinegar works by a different mechanism, slowing intestinal carbohydrate absorption. They address different parts of the problem. The effects are complementary, not redundant. If you are on insulin or sulfonylureas, drugs in the glipizide or glimepiride family, there is a more important conversation to have. Those medications actively lower blood sugar by stimulating insulin production or directly delivering insulin. Adding a beverage that also lowers blood sugar means your total glucose-lowering effect is greater than either component alone. That can push you into hypoglycemia, low blood sugar, which in a person over 65 is not a minor event. Before you add any of these drinks consistently to your routine, if you are on insulin or a sulfonylurea, talk to your physician. Check your blood sugar more frequently in the first 2 weeks. Know the symptoms: cold sweating, shakiness, confusion, sudden hunger, rapid heartbeat. If your glucometer shows anything below 70 milligrams per deciliter and you feel those symptoms, treat it immediately with 15 grams of fast-acting carbohydrate. That's the rule of 15, not something to skip. For everyone, if you have gastroparesis, delayed gastric emptying, which is a complication of long-standing diabetes, do not use apple cider vinegar regularly without medical clearance. It further delays gastric emptying and can create significant gastrointestinal distress. If you have active reflux, esophagitis, or ulcers, the same caution applies. And always dilute it. Always. 1 to 2 tablespoons in at least 200 milliliters of water. Never straight from the bottle. Now the third drink. And this one I want to explain carefully because the headline finding is remarkable, but the details matter. Published in Phytotherapy Research in early 2024, a research team conducted what's called an umbrella meta-analysis. They analyzed 11 separate meta-analyses on cinnamon supplementation in type 2 diabetes, effectively reviewing the totality of available evidence in one paper. The findings for fasting plasma glucose, a reduction of 10.93 milligrams per deciliter with p less than 0.001. HOMA-IR, insulin resistance, reduced by 0.61 units. Fasting insulin dropped by 2.01 IU per milliliter. These are not trivial numbers, and they are consistent across 11 different prior analyses that collectively represent hundreds of randomized controlled trials. The mechanism is different from both green tea and vinegar, which is exactly why all three together cover more metabolic ground than any one alone. The active compounds in cinnamon, specifically a class of polyphenols called procyanidin A-type polymers, directly improve the autophosphorylation of the insulin receptor. What that means in plain language, they help the insulin receptor do its job more efficiently. If our earlier analogy was a rusty lock that insulin's key couldn't open properly, these cinnamon compounds are the WD-40. They don't add more insulin. They make the receptor more responsive to the insulin that's already there. However, and I want to be completely clear about this, not all cinnamon is the same. There are two main types sold in supermarkets. Cassia cinnamon, which is the dark reddish-brown, tightly rolled kind that is by far the most common and cheapest, contains a compound called coumarin. Coumarin is hepatotoxic in chronic high doses. A single teaspoon of cassia cinnamon can contain enough coumarin to approach or exceed the tolerable daily intake for a person of average body weight. Used daily over months or years, this is not benign for your liver. Ceylon cinnamon, sometimes labeled true cinnamon, is a lighter tan color, has thinner multiple layers when unrolled, and contains less than 2% of the coumarin found in cassia. For daily use in the context of blood sugar management, Ceylon cinnamon is the appropriate choice. Half a teaspoon in 8 to 10 ounces of warm water, consumed in the morning on an empty stomach. It is not difficult to obtain, it costs very little, and the biological evidence for its metabolic effects is more robust than most people know. Let me now pull these three mechanisms back together, because the morning drink protocol isn't three separate interventions. It's one integrated strategy aimed at three interconnected problems that all worsen with age. Problem 1. Your liver is producing too much glucose overnight, contributing to elevated fasting blood sugar. Problem 2. Your cells, particularly your muscle cells, have become resistant to insulin, so the glucose that enters your bloodstream after meals isn't being cleared efficiently. Problem 3. Chronic low-grade inflammation from visceral fat is jamming the molecular signal between insulin and the cell. Apple cider vinegar addresses the liver and the intestinal absorption rate. Green tea's EGCG addresses the inflammatory pathway and hepatic insulin sensitivity through AMPK activation. Ceylon cinnamon addresses the insulin receptor directly, making the key fit the lock better. These are not the same tool used 3 times. They are 3 different tools addressing 3 different failure points in the same system. Here is another piece of research that rarely makes it into conventional conversations. The DIRECT trial, published in The Lancet in 2018, followed 298 adults between the ages of 20 and 65 with type 2 diabetes. Participants who underwent an intensive dietary intervention, primarily targeting weight loss and hepatic fat reduction, achieved full clinical remission, defined as A1C below 6.5% with no diabetes medication, in almost half of cases. Not improvement, remission. At 2-year follow-up, published in 2019, over a third of participants maintained that remission. This was not a young population. The mean age of participants who achieved remission was in the late 50s. Why does this matter in a video about morning drinks? Because what the DIRECT trial demonstrated biologically is that type 2 diabetes in adults is not an irreversible condition. The mechanism that drives it, hepatic fat accumulation causing liver insulin resistance and overproduction of glucose, is modifiable. The liver can be changed. The insulin resistance can be reduced. The trajectory of the disease is not fixed. That is the scientific foundation on which everything we've discussed today stands. You are not managing a condition that will only get worse. You are working with a metabolic system that remains responsive to the right inputs. Morning drinks are not a cure. They are a metabolic input, a consistent one, and consistency over time, aligned with the correct mechanism, is how numbers change. Enough about the mechanism. Here is what to do. Start in the first week with one thing only: apple cider vinegar. The reason to start here is that it has the highest quality recent evidence, the most direct effect on fasting glucose, and the fastest observable impact. You will likely see a change in your morning number within the first 7 to 10 days, which gives you something real to track and motivates continued adherence. The dose: 1 tablespoon, 15 milliliters, in 200 milliliters of water. If that is well tolerated after 3 to 4 days, you can increase to 2 tablespoons, 30 milliliters, which is the dose used in the majority of the trials showing the largest effects. The timing: 30 minutes before your largest meal, which for most people is breakfast or dinner. If your main concern is fasting glucose, your morning number, you can also take it before bed, which several studies have shown reduces the dawn phenomenon effect by directly suppressing overnight hepatic glucose production. Use a straw to protect your tooth enamel. Rinse your mouth with plain water afterward. Raw, unfiltered apple cider vinegar with the mother, the visible cloudy sediment, contains more acetic acid and polyphenols than filtered varieties. Let me anticipate 2 things I hear from patients every single time I recommend this. First, it tastes terrible. Yes, it does. That is the honest answer. You get used to it. You can add a small amount of lemon juice, which is also metabolically beneficial and masks some of the acidity. You can add a pinch of Ceylon cinnamon to the mixture, which again compounds the benefit. What you should not do is add honey or fruit juice to mask the taste, because you have just counteracted the glycemic effect you were trying to achieve. Accept the taste or find a preparation that makes it tolerable. Some patients prefer to mix it into warm water rather than cold, which rounds out the harshness slightly. Second thing I hear: I read somewhere it damages kidneys. This concern comes from case reports involving people who consumed very large quantities of undiluted vinegar over long periods. At the doses and dilutions we are discussing, 1 to 2 tablespoons in a full glass of water, there is no evidence of renal harm in people with normal kidney function. If you have chronic kidney disease and your GFR is below 45, discuss with your physician first. because altered acid-base regulation is a consideration in compromised kidneys. But for the vast majority of people in this audience, it is safe. In week 2, add green tea. 2 to 3 cups daily, in the morning or early afternoon if caffeine sensitivity is a concern. The catechin content that produced meaningful results in the research corresponds roughly to high-quality loose-leaf or matcha-grade green tea. Standard commercial tea bags contain catechins, but at substantially lower concentrations. If you want the EGCG levels that the research actually tested, look for a Japanese sencha, a Chinese dragon well, or matcha powder. Matcha, half a teaspoon dissolved in warm water, not boiling, delivers the most concentrated EGCG dose of any standard green tea preparation. Do not add milk. Milk proteins bind to catechins and reduce their bioavailability. Do not add sugar. Stevia is fine if you need the sweetness. The water temperature matters. Steep at around 70 to 80 degrees Celsius, not at a rolling boil, which degrades EGCG. 3 minutes of steeping is sufficient. I want to address the caffeine question directly. 8 ounces of green tea contains roughly 25 to 35 milligrams of caffeine. A standard cup of coffee contains 95. Most patients over 60 who are sensitive to coffee do fine with green tea at those levels, particularly in the morning hours. If you are genuinely caffeine sensitive, if even 1 cup of tea late in the afternoon disrupts your sleep, decaffeinated green tea retains the majority of its catechin content and is a fully valid option. The sleep point is not a minor footnote. Poor sleep quality in adults over 65 directly elevates cortisol, amplifies the dawn phenomenon, and worsens insulin resistance the following morning. If you are choosing between the EGCG benefit of regular green tea and the metabolic harm of disrupted sleep, choose the sleep. Get the decaf. I mentioned sleep and cortisol. Let me be specific about why this matters for people using this protocol. One of the mechanisms by which poor sleep drives blood sugar up is through elevated morning cortisol. Cortisol is one of the main hormones that signals the liver to produce glucose overnight. It is the primary driver of the dawn phenomenon in most people. If your sleep quality is poor and your cortisol is consistently elevated, you are working against the very mechanism that this morning protocol is trying to address. You can drink the vinegar, the green tea, and the cinnamon water every morning. And if you are only getting 5 hours of fragmented sleep every night, you are partially undermining the benefit. I raise this not to add another item to your to-do list, but because it is directly relevant biology. Sleep hygiene is metabolic medicine. In week 3, if both of the first 2 additions are going well and your numbers are trending in the right direction, add the warm Ceylon cinnamon water. Half a teaspoon of ground Ceylon cinnamon stirred into 8 to 10 ounces of warm water, consumed first thing in the morning on an empty stomach before the other drinks. You can also add a pinch of Ceylon cinnamon to your green tea if that is simpler. The goal is consistent daily consumption, not a perfect preparation ritual. Let me revisit why Ceylon cinnamon specifically matters, because I don't want this to be a throwaway line. Most of the cinnamon on grocery store shelves in North America is Cinnamomum cassia, also called Chinese cinnamon or Saigon cinnamon. It is inexpensive, widely available, and the type that most people mean when they say cinnamon. It also contains coumarin, a naturally occurring compound that is hepatotoxic in chronic doses. The European Food Safety Authority set the tolerable daily intake of coumarin at 0.1 milligrams per kilogram of body weight. A single teaspoon of cassia cinnamon can contain enough coumarin to approach or exceed that level in a person of average weight. For occasional cooking use, this is not a concern. For daily therapeutic consumption, it is. Cinnamomum zelanicum, Ceylon cinnamon, true cinnamon, contains a fraction of a percent of the coumarin found in cassia. The metabolic research that shows benefits for HOMA-IR and fasting glucose does not specify cinnamon type in all cases, but the studies showing no hepatic adverse effects use Ceylon or do not report coumarin levels. If you are going to use cinnamon daily, use Ceylon. One practical note on sequencing. The morning routine that I've seen work best for patients is this. Wake up, drink the warm Ceylon cinnamon water first, give it 10 minutes, then take the apple cider vinegar and water, then eat breakfast and brew your green tea to have with or after breakfast. That sequence means the cinnamon is working on your insulin receptors before food arrives. The acetic acid is slowing absorption as food enters your gut, and the EGCG is continuing its anti-inflammatory and AMPK activating work across the morning. It sounds like a lot when described in sequence. In practice, it takes less than 5 minutes and becomes automatic within a week. I also want to mention one post-meal intervention that compounds these morning benefits. A 15-minute walk after your largest meal of the day, not a gym session, not a structured workout, just 15 minutes of gentle movement, activates GLUT4 transporters in muscle through a completely insulin-independent pathway. Muscle contraction itself stimulates GLUT4 to move to the cell surface, bypassing the broken insulin signaling entirely. You don't need insulin to respond correctly. You just need the muscle to contract. In patients with limited mobility, even gentle movement of the arms and legs while seated produces a meaningful postprandial glucose effect. The research on post-meal walking consistently shows reductions of 20 to 30% in the 2-hour postprandial glucose spike. That is not a trivial number. It is the difference between a number that signals ongoing damage to your blood vessels and a number that does not. Monitor your blood sugar. If you have a glucometer, check your fasting number every morning and write it down. Not because you need to obsess over it, but because you need data to know whether what you're doing is working. Fasting glucose is the first number to move with this kind of intervention. It typically responds faster than A1C, which reflects a 90-day average and changes more slowly. If you're not seeing any movement in fasting glucose after 3 to 4 weeks of consistent use, that's important information too. It means there are other factors at play: sleep quality, stress levels, overall carbohydrate load in your diet, medication interactions, that warrant a conversation with your physician. Let me be specific about what to track and when. Before you start this protocol, today, before tomorrow morning, write down your fasting glucose. Write down what medications you're on and the doses. If you've had a recent A1C measured, note that too. This is your baseline. Every morning for the next 30 days, record your fasting number before you eat or drink anything except water. At the end of 30 days, you will have data that tells a clear story. Either the protocol is working or it isn't working as well as expected, or it's working but something else is pulling the number in the wrong direction. Data is the difference between guessing and knowing. When you see your physician for your next appointment, bring those 30 days of data. Your doctor cannot track what you don't measure. 30 days of morning glucometer readings is more actionable information than any single A1C measurement because it shows the pattern, the overnight trajectory, the day-to-day variability, the response to different meals or activities. If you want your physician to take your metabolic management seriously, show up with data rather than symptoms. If you are on insulin or sulfonylureas and you begin seeing fasting numbers significantly lower than usual, say dropping from your baseline of 140 to 160 down into the 90 to 110 range consistently, that is actually good news, but it means your medication dose may need to be adjusted. Do not adjust your own medication dose. Share those numbers with your doctor and have that conversation. The goal is not to prove the drinks work. The goal is to optimize your metabolic health, and that may require recalibrating your treatment. For patients on metformin alone, the interaction risk is low. Metformin by itself does not cause hypoglycemia. It reduces hepatic glucose production, but it doesn't directly force glucose below normal the way insulin or sulfonylureas do. Adding these beverages to metformin is generally well tolerated. That said, monitor your numbers in the first 2 weeks because individual responses vary more than any clinical trial can fully predict. There is also a question I want to address that I hear often from patients who have been managing this condition for years. How long do I have to keep doing this? The honest answer is that the underlying mechanisms we discussed, the muscle drain, the liver surge, the inflammatory disruption of insulin signaling, are chronic processes that worsen with age. The morning drinks address them at the biochemical level as long as they are consumed. They are not a 10-day course that produces permanent change. They are a daily metabolic input, the same way your medication is a daily metabolic input. The difference is that they cost a few dollars per month, have no serious side effects at recommended doses, and work on pathways that your medication does not address. For most people, the question becomes not whether to continue, but whether it becomes part of their normal morning routine, which most patients find it does within about 3 weeks, once the habit forms and the numbers confirm the effect. I want to close with something I think about whenever I look at a patient who has been living with a type 2 diabetes diagnosis for 5 or 10 years and hasn't been given an honest picture of what is physiologically possible. The direct trial showed us that remission is real, measurable, and achievable in adults well into their late 50s. The mechanism it worked through, reducing hepatic fat, restoring liver insulin sensitivity, reducing the overproduction of glucose, is the exact same mechanism that apple cider vinegar, green tea, and Ceylon cinnamon are addressing at a biochemical level through different pathways in a way that is safe for daily use, inexpensive, and supported by peer-reviewed evidence. None of these three drinks is a drug. None of them will replace your medication without your doctor's involvement. But they are not trivial. They are not folk remedies dressed up in science language. They are compounds with identified molecular targets, tested in controlled human trials with published effect sizes. And they work on mechanisms that worsen specifically with age, the muscle loss, the overnight liver glucose surge, the inflammatory interference with insulin signaling, which is exactly why they matter more, not less, to someone over 55. I want to say something directly about the frustration that I know many of you carry. You have been told for years, perhaps decades, to eat less and move more. You've heard it from your doctor, from health campaigns, from everything, and yet the numbers haven't moved the way you hoped. The A1C is still higher than it should be. The fasting glucose is still spiking in the morning. The medication keeps getting adjusted upward, and nobody has explained why. Nobody has connected the sarcopenia to the blood sugar, the liver to the morning spike, the visceral inflammation to the insulin resistance. They gave you a diagnosis and a prescription and sent you home. That is the gap this channel exists to close. Not to replace your physician, you need your physician, but to give you the molecular understanding that transforms you from a passive recipient of treatment into an active participant in your own metabolic health. Because patients who understand their mechanisms make better decisions. They ask better questions at their appointments. They notice patterns in their data that matter. They are harder to dismiss. The research is clear on what is possible. A meta-analysis of 722 patients with type 2 diabetes showed that consistent green tea consumption reduced insulin resistance significantly. A grade-assessed meta-analysis published in 2025 showed that apple cider vinegar reduced fasting glucose by nearly 22 milligrams per deciliter and A1C by over 1.5 percentage points. An umbrella analysis of 11 separate meta-analyses confirmed that Ceylon cinnamon reduces fasting plasma glucose and directly improves insulin receptor function. The direct trial showed that nearly half of middle-aged adults with type 2 diabetes can achieve clinical remission with the right intervention. These are not fringe findings. They are peer-reviewed, replicated, and published in respected journals. The science exists. The mechanism is understood. The protocol is simple enough to do before breakfast every morning. What it requires is consistency, data tracking, and a physician relationship where you can share what you're observing and adjust accordingly. What you can do today, not next week today, is this. Pick up raw, unfiltered apple cider vinegar and a box of high-quality green tea on your next grocery run. If you can find Ceylon cinnamon, all the better. Start tomorrow morning. 1 tablespoon of vinegar in a full glass of water before breakfast. 2 cups of green tea through the morning. Half a teaspoon of Ceylon cinnamon in warm water when you wake up. Write down your fasting glucose every morning for the next 2 weeks. Give it time. Metabolic change doesn't happen overnight, but it does happen. And the evidence says it can happen for you. Your doctor isn't lying to you. They're working from guidelines that haven't caught up with the science. Your job is to understand the mechanism, track your own data, and have an informed conversation about what the numbers show. This is Dr. Michael Reed. Know your numbers. Own your health.